Our next speaker is Dr. Darakhshanda Khurram. He's a consultant pediatric ophthalmology in Moorfields Eye Hospital Dubai, and he will talk about case scenario in pediatric ophthalmology. Please.
Hi, good morning, everyone. I'm very happy to be here, and I would like to thank Dr. Salman for inviting me. I don't know how much representation pediatric ophthalmology gets here in last 10 conferences. So here I am. I'm a pediatric ophthalmologist at Moorfields. I'll be talking about pediatric ophthalmology challenges or challenging cases in terms of orbital vascular anomalies. We'll be talking about nystagmus, abnormal eye movements, what you need to know and when you need to worry. And I'll also be sharing a case report involving ocular adnexal conditions. So first off, orbital vascular anomalies. It is a heterogeneous group of vascular lesions within the orbit, and there's a diverse spectrum that we encounter, which are mainly vascular tumors, or they can be vascular malformations. But before I go forward, because of the complex anatomy of the orbit, and also all these conditions, they are so challenging with overlapping features, it becomes very difficult to differentiate these subtypes. So as my first case, I'll be sharing some pictures and videos, and I have consent from the parents to share them. So my first case is a 4-week-old baby that was referred to me with a 3-day history of a right eye bulging forward. As you can see in this picture, it's a very subtle asymmetry between the eyes, and the right eye, the only sign that gives away is the subtle fullness of the right globe orbit. So the baby was preemie. He was born 32 weeks with a birth weight of 2.2 kgs. He was hemodynamically stable. The only thing was he was started elsewhere by on Tobrix, which is a tobramycin eye drops for the redness in the right eye. Ocular examination revealed non-axial proptosis in the right eye, and there was slight exposure keratopathy with some punctate erosions on the inferior cornea. Rest of the eye examination was absolutely normal. On exophthalmometer, I found that there was a 2 millimeter proptosis difference between the two eyes. Left eye was unremarkable. Now, at this point, I was thinking about infantile orbital hemangioma, vascular rhabdomyosarcoma, and lymphatic hemangiomas. So unfortunately, that day, usually we have a colored Doppler in the clinic, but that day it had gone out for maintenance. So I could not do that imaging. But these imagings, they are vital tool for us, because in case of subtle asymmetry between the eyes or the very deep lesions, we won't be able to, imaging really helps us differentiate between different subtypes of vascular anomalies. So superficial lesions, which have atypical presentation, deep lesions, which are difficult to assess on physical examination, and also prior to the therapy, you need to know the exact dimensions and the extent of the lesion. Ultrasound is the first-line modality for most cases. However, MRI is far more superior, especially if you're dealing with the large lesions, and also if you want to see the extension of the lesion. So here is the MRI of the child. As you can see in both axial and coronal scans, there's a large hyperopic lesion. In the coronal section, you can see it is almost engulfing 2/3 of the globe, and in the left eye, in the right eye, on the axial scan, you can see the hyper-intense mass that is causing consequent proptosis. These lesions are lobulated, and they have a hyper-intense shadow. So based on that, diagnosis of capillary hemangioma was made and the patient was started on propranolol. I usually deal with these children, treat these children with their pediatrician, cardiologist, and neurologist to rule out before we start treatment for the capillary hemangioma. Patient needs to be evaluated by cardiologist, pediatrician, and the neurologist. So once you decide the treatment, propranolol is the mainstay of the treatment. The dose is, initial dose is 1 milligram per kilogram body weight, which is subsequently increased to 2 milligram per kilogram body weight. And keeping in mind the weight gain, eventually you give the maximum dose of about 3 milligram per kilogram body weight. And the follow-up visit, I usually keep it at like about 3 weeks, 3 months time. And in the first follow-up visit, I saw a significant regression in the proptosis. Now, my second case is a 3-month-old baby who was referred to me by the pediatrician with 1-week history of increasing swelling of the upper eyelid. And there were periorbital red spots. Patient was hemodynamically stable, journal health was okay, birth history was full-term C-section. Patient was also already started on Tobrix eye drops by the referring physician because of the redness. On ocular examination, as you can see in this picture, there is a non-axial deviation of the right eye. It is turned towards the lateral side. And there is a lobulated appearance of the lid, lesion. It is droopy, it's causing mechanical ptosis, and there is fullness on the inferior and the nasal part of the eye. Otherwise, the rest of the eye examination was unremarkable. Conjunctiva was mildly injected, but there was no discharge or watering or any kind of pain in the eye. When I was doing the superficial palpation, it was non-tender, and even the B scan, even the fundus examination did not show any involvement of the optic nerve. Now, I was lucky to have B scan here at that time in my clinic, and as you can see in the upper picture, the first one, the gray scale of the ultrasound, it shows a cystic lesion which has a hypoechoic center. And on the color Doppler, you can see the vascular elements, viscolarity by the presence of these colors. This is the MRI scan of the child, and as you can see, a very, very large capillary hemangioma extending towards the back of the orbit, hyperintense mass, and also causing compression or deviating the eyeball towards the left lateral side. And if you can see the sinuses, they are empty, but if you leave these children untreated, then capillary hemangioma not only develops outside, but also intraorbitally, and can cause some respiratory distress in these patients. So what is a capillary hemangioma? It is a localized proliferation of the vascular endothelial cell. It's one of the most common benign orbital tumor. It can be either superficial, cutaneous, or subcutaneous, or deep orbital lesion. Large tumor basically affect the vision. How do they affect the vision? By causing mechanical ptosis and causing the obscuration of the visual axis. They can also impinge on the globe, causing anisometropia. Anisometropia is the difference in the refraction in two eyes, and they can lead to significant astigmatism in these patients. They're functionally and cosmetically disfiguring, and that's the reason why high-risk cases should be treated very early, because they can not only cause respiratory problems, there's a high risk of losing vision permanently from optic nerve compression and exposure keratopathy. Most of these children, about 20% of the infants with capillary hemangioma, they have multiple hemangioma. If you have a child with 5 or more cutaneous lesions, especially with geographical arrangement, it warrants up further assessment to rule out any visual involvement and faces syndrome. Also, depending upon the growth and location of the lesion, these children, they can have severe systemic complications like Kasabach-Merritt syndrome, which is a rapidly proliferative large vessel hemangioma, which is associated with platelet sequestration, severe thrombocytopenia, and DIC. Large hemangioma of the nasopharynx and oropharynx, they can cause obstructive respiratory, or obstruction of the respiratory passages. Now, not very long ago, the main stay of the treatment was steroids. Systemic steroids, especially prednisolone, was given to these children, and intralesional steroid injections were also given to reduce the growth or shrink the size of the tumor. But ever since the advent of propranolol beta blocker, now that's the first-line treatment, and we have seen some remarkable results from it. How does it affect? It affects by reducing the expression of the genes for VGF, BFGF, MMP9. And this results in the apoptosis of the capillary endothelial cells. Propranolol is, however, not without its side effects, can cause bradycardia, hypotension, can cause hypoglycemia and masking its symptoms. But what are the advantages over steroids? There are numerous. These patients can avoid dysmorphic periocular calcification, hyperpigmentation, growth retardation, to name the few, and steroid-induced glaucoma. So this is a child, case 1 and case 2, before the treatment, after the treatment. Case 1, the post-treatment treatment picture is 10 months, and for case 2, as you can see, it has completely resolved. The child is off beta blockers now, and it is taken 18 months after the initial initiation of the treatment. So now I'm going to be talking about abnormal eye movements. Abnormal eye movements in infants can be a manifestation of severe neurological or neuromuscular condition that can have or can lead to grave consequences. So what do you need to know and when you need to worry? I'll be showing you a couple of videos of infants that I saw in my clinic back to back within few months' time. And they had a very bizarre eye movements, and they were intermittent, and we did a comprehensive workup on them to differentiate and diagnose. So first off is an 8-month-old baby, full-term normal delivery. General health is stable. Chief complaint was recent onset intermittent jerky vertical eye movements. So I'm going to play the video for you. So, anybody, any guesses? So, basically, the child has a conjugate eye movement, down beating. So this is a down beating nystagmus. But it was only intermittent. It happened in bursts. There was no triggering factor like sound or light. It would just happen. What I noticed was it happened when he was converging, or when you put your face very close to his face and he's trying to focus. This is my second patient, and 10 weeks old baby, general health absolutely fine, and similar kind of presentation. I'm going to play the video for you. I'll play it again for you. So at first instance, it looks like it is an upbeat nystagmus, but towards the end of the video, if you pay attention, it is actually downbeating nystagmus. Same kind of features. At that point, I was thinking about lesions. I was thinking about cerebromandibular lesions, metabolic lesions, mitochondrial lesions, and I referred the patient to neurologist for full workup. So in these two patients, what we saw was abnormal eye movement, which was characterized by brief episodes of intermittent down gaze or with vertical nystagmus. It occurred both in supine and upright, and there were no triggers. Otherwise, neurological exam was absolutely fine. Obviously, owing to the sunset sign, I was thinking of raised intracranial pressure, so I referred the patient from neurology, and they did the comprehensive workup. MRI was normal, ECG was normal, EEG was normal during the bursts and when the bursts were not happening. Urine was normal for MVA and VMA. So after excluding neuroblastoma and opsoclonus and pheochromocytoma, the diagnosis was benign positional vertical opsoclonus. Now this is a new entity. However, it has been reported in literature. It's also known as paroxysmal tonic down gaze, and it's a pseudo-sunsetting sign. It's an abnormal eye movement that usually resolves spontaneously after 2 to 4 weeks, and that's what happened in our patient as well. It vanished, it resolved, and it was so hard to convince the parents to come to the clinic for assessment and follow-up checkup because parents were not seeing it and there were no further concerns. So, however, we followed these children up to 2 years, and they subsequently had a very normal neurodevelopment. The reason, or it is theorized that it is because of the immature myelination of the cortico-mesencephalic vertical gaze pathway. If you review the literature, literally there are 1 or 2 or maybe handful of cases of about these episodic vertical nystagmus. The only thing that I found was from Japan, and they had a large series of 8 children with PTD, and they reported that the disorder appeared between 1st and 5 months. 5 infants were preterm, and they had some sort of perinatal injury. ECG were abnormal, and when they followed them up, 5 out of 8 later developed West syndrome. Another study that came out of Israel in 2016, they reported a long follow-up of 6 children with PTD, and their infants were healthy babies. PTD started between 3 weeks to 5 months, and they followed them up for 2.5 years, and all the children, they achieved their normal developmental milestones. I'm going to play another video. It's a very interesting, and if anybody in the audience can pick up what kind of ocular movement this is. Anybody? It can cause torticollis, but it's not. Let's play it again. What? Exactly. So basically, the child is using our head thrust to guide the eye movements. The patient does not have smooth pursuit movements, which are the movements of following a target. And you can see that he has difficulty moving his eyes from one place to the other place, so he uses his head thrust to initiate that movement. I'll play it again, and you'll be able to follow it. And in the last, the head thrust is amazing. Okay. So basically what is happening is these patients, they have, so this was a classic case of congenital oculomotor apraxia. These patients, they have abnormal or hypometric saccades. They are unable to initiate it, and even the amplitude is reduced. Because when babies are born, they don't have saccades. Saccades is the movement in which you fix on something and then you can jump your gaze to another object. Because when babies are born, they don't have saccadic movements. What they have is a very reduced saccadic movements. And pursuit movements, they come later on after 6 months, 8 months time. So, and how do you define pursuit movements in younger children is it's a hypometric saccade. So since they don't have, or they have abnormal saccades, they are labeled as children with reduced vision. Actually, their visual maturation is delayed because they are not able to generate the eye movements. When they are able to control their heads, that's the time they start engaging and fixing and following. And because they cannot follow, what they do is they use their head thrust by engaging the vestibulo-ocular reflex and then guide the movement of the eye towards to the different side of where the head is. They also can present with delayed motor speech, delayed motor speech and cognitive development. Congenital ocular apraxia can be a feature of severe metabolic disease such as Joubert syndrome. This is the last case that I'm going to present. It involves ocular adnexal tissue, and it's very important for general pediatrician if there are any here, because it will relieve a lot of stress from the patient as well as the parents. And it is congenital nasolacrimal duct obstruction. Epiphora, it is #1 cause of epiphora in children, and it is because of the incomplete canalization of the inferior part of the nasolacrimal duct. These children, they present with watery eyes, sticky discharge, matted lashes, and if you do clinical assessment on them, there is a late disappearance of the fluorescent dye. How do you treat it? You do hydrostatic pressure, which is called as Kregler maneuver. How do you do Kregler maneuver? You place your finger on the medial canthus. That will block the reflux going back into the canalicular system. Once that happens, you press the finger and go towards the movement or direction of the nasolacrimal duct. That will cause the positive pressure, the hydrostatic pressure will increase, and it will rupture the membrane that is blocking the rear end of the nasolacrimal duct. But that is not the case. The case is 1-week-old baby, preterm, normal delivery, presented in my clinic with 5-day history of swelling on the nasal side or the medial side of the right eye. It was bluish in color. It was solid, and anything that is close to the eye, we first of all think of hemangioma. We need to rule out encephalocele, dermoid, and nasal gliomas. After ruling all these things out, diagnosis of congenital dacryocystocele was made. It is theorized that basically the obstruction is at common canalicular level, above at the level of valve of Rosenmuller, and the inferior portion where the valve of Hessner is. Now these two get blocked, and the fluid that is trapped there cannot drain. So once the fluid cannot drain, it needs to, obviously it gets infected, anything stays stagnant gets infected. It starts bulging. Where does it go? It goes through to the nasal side and to the space where the, underneath the inferior turbinate. So if you do an endoscopic view, take the endoscopic view of these children, you will see a yellowish lesion-like appearance in the airway passage. That's the inferior turbinate, and the yellow thickening that you see behind is the intranasal cyst. Now, the most important thing that I want to emphasize, that's the reason I'm presenting it, is children, infants are obligate nasal breathers. Dacryocystocele is a bilateral phenomena in 90% of cases. So once you have blocked airway passage, then it becomes very difficult for them to breathe, and it can result in respiratory distress. There are a lot of literature. You can find a lot of articles published under this entity. And there's a very real chance that when the baby is breastfeeding, he can actually choke. So because of the serious nature of this, you need to treat it. And how do you treat it? You do probing, and you do endoscopic marsupialization of the intranasal cyst. Basically, that involves making 2 cruciate incisions and draining the cyst out. So this is the intranasal cyst of our patient, and before and after marsupialization of the intranasal cyst that got drained. So dacryocystocele is a rare presentation of CNLDO. Potentially it is life-threatening, as can cause respiratory distress. Endoscopic guided marsupialization is an effective treatment. Thank you very much.
Thank you very much, Dr. Khurram, for this elegant presentation. Now it's time for discussion. May I ask our speakers, please, Dr. Khurram? Dr. Walid?
Thank you for all nice presentation. My question is for Dr. Walid. Calculating the dose of insulin in case of high blood sugar, you give us formula for children above 10 years. 1,800 divided the total number of doses. What about the calculating the dose for children less than 10 years?
Yeah, well, first of all, I want you to know those are practical advices. They're not evidence-based, but you will find them in any guidelines and textbook. So we still use the same rule. We call it the 800 rules or the 700 rules. You still divide it by the total daily dose, but you change your target. So I say the target blood sugar for children 10 years and older is 100. The younger the child, the higher the target. So if you have a 5-year-old child, the target will be above 150. You have to be very conservative. You want to make sure you will not induce hypoglycemia, so you increase your target. And remember that the total daily dose is going to be small. So when you divide 1,800 by a total daily dose, which is maybe could be 10 units, you will get 180, which means for every 180 points above your new target, which will be in this case 150, you will give 1 unit. So for younger children, we recommend that they have to use the pens with half units. There are only 1 pen in the market that can give half unit insulin, and those are not disposable pens. They are reusable pens. So children younger than 7 or 6 must use the pen with the half unit. So when you do this target and the calculation, instead of telling them for every 180 points, you give 1 unit, you tell them for every 90 points, you give half unit. So it becomes more practical.
The dose for the 3 meals is the same, or we have to do some manipulation? Say the lunch will be a bigger dose than the dinner, or the 3 doses will be the same?
I don't know. It varies between children. You have to see the numbers from the parents, and you have to do the recommendation based on that. However, if you hear from the mother up front that my child doesn't eat breakfast usually and they eat large dinner, then yes, you have to use different calculation. That's why the first line treatment for children with diabetes of young age is in fact insulin pump. It is not the multiple daily injection. With the insulin pump, you can give 1/10 of a unit. You can give actually 1/2 of a unit, and then the pump can stop automatically. So before hypoglycemia happens, all the newer pump has the prediction low glucose suspension feature. But if the family does not have insurance coverage for insulin pump, we have to manage with the resources. So back to your question, you don't need to use the same calculation for all the meals. But if the family tells you, oh, that's too much, I cannot really comprehend all these things, then you need to use something simple.
Please, I want to ask a question for Dr. Khurram regarding the cases of opsiclonus, doctor, that you showed us. We know all that opsiclonus is associated with a neuroblastoma. So if the initial images were negative for any evidence of tumor, do you advise for follow-up images? And if we have to do that, for how frequent, for how long, and how frequent?
So that's a very good question. Opsoclonus is related to cranial lesions. In these cases, the episodes were intermittent. They were not continuous. If you've seen a child with opsoclonus, there will be repetitive movements all the time. There will be time when he'll be able to converge and stabilize it, or with some kind of a head posture, he'll be able to attain a null point and dampen the opsoclonus. Any child with this grave diagnosis of having some kind of a cerebral tumor or lesion, they require, immediate intervention. We don't keep them under our follow-up. We immediately refer them to a neurosurgeon or neurophysician. If the child is treated, I usually see them 4 monthly basis. What we do is, if we can achieve or we can take visual fields on them depending on the age group that they fall on, or the OCT. Now we have handheld OCT just to see what kind of optic nerve changes are happening. Other than that, ophthalmic input is going to be very limited, apart from monitoring the opsoclonus. There are now machines available that can do video imaging of the nystagmus, eye movement patterns, and as far as the nature of these kind of nystagmus is concerned, it does not change over time. But yes, fatigue, fever can exaggerate and dampen it.
Does it matter if they were horizontal rather than vertical?
So anything that is horizontal is less ominous. Anything vertical, usually it just, gives me...
This was actually my point. To start with vertical nystagmus, shall we rule out brainstem lesion? Vertical. Yeah.
Any vertical nystagmus, as I said, it's a straight referral to neurologist and neurosurgeon and pediatric neuroradiologist to find out any kind of lesions. Sometimes some lesions are masquerading. They are very small, so we usually ask them to take, 1 millimeter cuts to detect where the lesions are. So yes, it's a grave diagnosis.
Yeah, with the second case of vertical nystagmus, the second case you projected, shall we go for the diagnosis of spasmus nutans? As it is, there were head nodding, vertical nystagmus, and shoulder nodding. Of course, it's benign, but by exclusion. Shall we go for it?
So, just like diabetes, you have a checklist. Any patient comes to you with the condition of diabetes, you do your blood sugars, you do hypertension, cholesterol, and everything. Any child that presents with nystagmus, any kind of nystagmus, whether it's horizontal nystagmus, vertical, torsional, rotation, as a checklist, you need to do neuroimaging to rule out any kind of a cranial lesion. If the parents are not convinced, it's our job to convince them that as a part of a protocol, it is mandatory to do neuroimaging. So it's very important.
Question for Dr. Walid about monogenic diabetes, moody onset and neonatal diabetes, monogenic type. How we calculate the oral hypoglycemic medications for this type of diabetes for children? Maturity onset diabetes, type 2 diabetes in children. What's your plan of
Maturity onset and type 2 are not the same. So is your question about MODY or type 2?
Both.
MODY?
Both.
Both. So what is the question?
What's your management plan? You start the oral hypoglycemics for this age?
So
or
let's
how you
talk
calculate?
about, MODY is a very diverse conditions of diabetes. First of all, MODY is only 5% of diabetes in children. There are MODY that needs no treatment, like MODY 2. There are MODYs that can be treated with oral agent, and there are MODYs that need insulin from first stage. So it depends on which type of MODY. So there is no one answer. For type 2, if they present mildly, you can start them on metformin. If they present moderately, it's going to be metformin plus basal insulin. If they present severely, it's going to be multiple daily injections. So what is the definition of mild, moderate, and severe? It is the level of ketone and the level of HbA1c. So HbA1c more than 9% or large ketone, you're going to treat them like you do type 1. Basal insulin, prandial insulin, until you subside the findings. And then we can stop the prandial insulin and start metformin, continue the basal insulin. Later on, if the patient takes the issue seriously and they lose weight, we might be able to stop basal insulin and continue metformin. In my practice over the past 25 years, I was able to actually stop everything, including metformin in maybe 3 or 4 patients only. But the vast majority will end up taking metformin and basal insulin.
Thank you very much for our.
I will ask later.
Thank you so much for our elegant speakers, actually keynote speakers. Now we'll have the coffee break. Distributing of the awards, then coffee break. Now there is coffee break. We'll be back by 11. Yeah. Thank you. Yeah, it's 11. 11 minutes.